So I'll be talking about nail in immunodermatological disorders. It's a huge, huge area to talk about, but I will limit my talk only in 4 diseases: nail psoriasis, lichen planus, nail in connective tissue diseases, and autoimmune blistering disorders like pemphigus and bullous pemphigoid. I have no conflict of interest. I forgot the slide. So I think first we should all recapitulate, because these are truly neglected area which I'm passionate about, both nail and tropical dermatology. So we should recapitulate the basic anatomy. We have proximal nail folds, we have lateral nail folds. This semilunar white part is the visible part of the matrix, which is distal matrix. That means we have a proximal matrix also. And then there is a nail plate which overlies the nail bed, which is very highly vascular, and that's why it appears pink in color. Otherwise, it's highly keratinized structure, and it is white in color. This is onychodermal band, which is a very closely, tightly adherent band and limits the boundaries of nail bed, because beyond that there is hyponychium, which has normal dermatoglyphics. And then there is cuticle, which is a semi-transparent membrane which adheres the proximal nail fold onto the nail plate, and it seals the space, so there is no space. If the cuticle is destroyed, then there is a potential space, and it can be invaded by candida or bacteria or whatever. On the right side, there is a sagittal section. And what is very, very important to know is the extent of the nail matrix, which is highlighted in green color. And as I said, the proximal distal matrix is white, while the proximal matrix extends proximally from the proximal nail fold about 3 to 4 millimeter. And this is a sacrosanct area, because this is the area from where the nail plate grows. And if there is a pressure in that area, or if there is any problem which can be a systemic problem, it is the nail matrix that suffers, and it is everything is represented on the nail plate. So we should remember, that this is very important area. I will also like to highlight that there are 3 parts of the nail matrix: proximal, intermediate, and distal, which forms 3 parts of the nail plate. The top third part is dorsal nail plate, intermediate, and ventral. So we should remember that if there is the ventral part of the nail plate is also contributed by the nail bed. Coming to the first part, nail psoriasis. Then why know about nail psoriasis? Because nail changes often accompany the skin lesions. The prevalence varies from 20 to 50%, with an estimated lifetime incidence of 80 to 90%. It is seen in up to 86% in patients who have arthropathic psoriasis, but the isolated nail involvement is seen only in 5 to 10%. But considering the incidence of and prevalence of psoriasis in general, this 5 to 10% is a whole lot of patients. Fingernails are more affected than toenails, and prognostically, it's important to remember that nail changes can be a surrogate risk factor for the development of psoriatic arthritis in future. So if patient has nail changes in psoriasis, you need to be more cautious during follow-up for the development of psoriatic arthritis. So the clinical feature of nail psoriasis will depend on if the matrix is involved, if nail bed is involved, or if the lateral nail folds are involved. And this is the whole list of changes which you can see. If the nail matrix is involved, we have pitting, leukonychia, Bowes line. Onychomatosis means proximal separation of the nail plate from the nail matrix. Red spots in the lunula, crumbling of nail plate, trachonychia. And we'll take this one by one. So you need to understand how the pits are formed. This is, I have already shown you this picture. And so you can see this is the nail matrix. It's very difficult to And this is a parakeratotic. We know that, the hallmark of psoriatic pathology is parakeratosis. That is incomplete keratinization. So this is happening in the proximal part of the nail matrix, which forms the topmost layer of the nail plate. So when, with the growth of the nail plate, this parakeratotic scale moves up, it lies on the topmost part of the nail plate, and it's a very, very friable structure, and it ultimately falls off, forming a pit, right? So that's how the pit is formed, and these are the pits. Initially they can be covered with white scales, which are parakeratotic columns, and when they fall off, they leave behind pits. And the differential diagnosis of pits, as we know, is the most important is alopecia areata, where they are very fine and, closely packed pits, while in the psoriasis, they are irregular, they are randomly placed, and when few of the pits, they become confluent, they form a very big gap, which is known as alkonexus. Coming to leukonychia, it is seen in 20% of the patients. They appear as irregular white patches in the nail plate, and on onychoscopy you can see these white spots on the nail plate. And how are they formed? Now the parakeratotic scale is not in the proximal matrix, it is in the intermediate and the ventral matrix. So when this parakeratotic column, it moves forward, it lies in the intermediate and ventral part. It is unlikely to be shed because the normal dorsal part of the nail plate is there, and these parakeratotic cells appear white in color, and they giving the leukonychia. And these are Bose line. I need not explain. These are the transverse lines running parallel on onychoscopy. And then we come to the crumbling of the nail plate. It's the extreme sequel of entire nail plate matrix involvement for prolonged periods. And it can be seen in 10 to 15% of the cases, both in toenails and the fingernails. And this is on the fingernails. Now coming to the nail bed manifestation, it is onycholysis, means painless separation of the nail plate from the nail bed distally. Proximally, if it happens, it's onychomatosis. And it is subungual hyperkeratosis, which again cannot happen without onycholysis. Oil spots or the salmon patch are hallmark, splinter hemorrhages. So coming to onycholysis, it can come either from the involvement of the hyponychium with the disruption of the onychodermal band and leading to onycholysis, or there can be psoriasis of the nail bed, and when it progresses distally, it can give rise to onycholysis. And you can see the onycholyzed nail plate, because it is not attached to the vascular nail bed, will appear white in color, and it will have a characteristic red proximal margin. Now that's very, very important, because onycholysis can be seen in many other conditions. Now this is the red hallmark, and there you see the salmon patch also. Now, as I said, onychomycosis is also characterized by onycholysis. There can be trauma-induced. People go for manicure or trauma, and this can also lead to onychomycosis. You have done your, I think, onychoscopy workshop today in the morning, I was seeing in the program. So in onychomycosis, there is a proximal jagged margins or spikes of onycholysis. In psoriasis, there is characteristic erythematous border, right? While in traumatic onycholysis, it's bland. So it's very smooth, it's not marginated by erythematous border. Coming to subungual hyperkeratosis, and it is because of the accumulation of the keratotic cells. It is more marked on toenails than fingernails, and you can see, because subungual hyperkeratosis also occurs in onychomycosis. But in psoriasis, it is whitish, it is compact, while in onychomycosis, it is crumpled. We call it as ruinous aspect. It is very fragile, right? So that's how you differentiate it. Oil drop or salmon patch are because of the glycoprotein deposition. You can see on the fourth finger, and on the ring finger, and you can, while on dermoscopy, it becomes very apparent as a yellowish deposit which is ill-defined. And you can also see these, linearly arranged splinter hemorrhages. And this is because the orientation of the blood vessels in the nail is like this, nail bed. So you will see splinter hemorrhage, and this is another thing, because splinter hemorrhages get more recognized when you do onychoscopy. And when I say onychoscopy for vessels, it is always polarized mode with an interface. Coming to nail fold, we have paronychia, acropustulosis, psoriatic plaques, and when they are all present, when the psoriatic plaques are present on the nail folds, whether it is proximal or distal, and nail psoriasis and arthropathy, I said it's a surrogate marker for the development of psoriatic arthritis. You can see the involvement on the toenails, on the ring finger and the little finger, and here. So everywhere there are nail changes, and there is a erythematous border proximal to the onychalized nail plate. And this is because there is a close anatomical relationship between the DIP joint and the nail unit, and enthesitis and arthritis both can happen. So how do you diagnose nail psoriasis? It's slightly difficult for the beginners if there is isolated nail involvement, but if there are, you can look for clinical clues. You can look for erythematous scaly lesions on the elbow, on the knee, on the lower sacral area, on the scalp. There can be family history. There are specific nail lesions which I told you just now. You can do onychoscopy to have a better idea of what the nail lesions look like. And last but not the least, biopsy. And this will depend on what you are biopsying. If you are biopsying a nail pit or leukonychia, it has to be a nail matrix biopsy. And when I say nail matrix biopsy, it always has to be distal matrix biopsy, because proximal matrix will cover the gap. You don't need to suture it. It has to be 3 mm punch biopsies. Coming to treatment of nail psoriasis, we have topical, intralesional or intramatricial or intrabed, and systemic or biologic. But are we justified using them only for nail psoriasis? There is a lot of cost involved and a lot of side effects and pre-treatment workup. So the general principles are: trim the onychalized nail plate, avoid Kobner's phenomena in the form of trauma. So how can you avoid trauma? Is by stopping nail biting, filing, avoid using artificial nails, don't use too much of cosmetics, nail paint, and remove them frequently, avoid cleaning the undersurface of the nails with sharp tools. So there are recommendations for the treatment of nail psoriasis. I was part of this group, expert group consensus published in JAD. So if there is only nail matrix involvement, if nail bed involvement, and if nail matrix and bed both involvement, but the nails involved are less than 3, then the first line treatment is, for all the 3, is topical corticosteroid and vitamin D combination, like we have available to us, or there can be intramatricial injections. I give intramatricial injections left and right even when there are 8 or 9 nails involved. If there are more nails involved, then you can go for second line treatments or systemic therapy. Now the advantages of injection therapy or intramatricial injections are that it's a targeted therapy. In alopecia areata, if there are single patch, we give intralesional therapy, intralesional steroid injection, exactly like that. The drug is available at the site in higher concentration, and there is a pool which is created at the site of, drug pool created at the site of pathology, and there are no drug interaction, no systemic side effect, no special formulation required, no equipment required. So it's just a skill which you need to acquire. So coming to an example, this was a dystrophic nails you can see in all finger and toe in a 26-year-old unmarried female who was having these lesions for more than 3 years. She had taken multiple courses of systemic antifungals, and she postponed her wedding. And these were the toenails. So we did a biopsy. The biopsy was consistent with psoriasis. So there were treatment options. We wanted for 14 nails involved total, no skin, no joint involvement. So we gave her option for acetretin and methotrexate. She denied because she was to get married. So what I did, topical treatment would have been very difficult, and absorption is very limited. So what I did was I gave intralesional steroid injections, triamcinolone acetonide 5 milligram per ml, 4 weeks. I gave 8 injections over a period of 11 months, and you can see the result. They are just unbelievable, and there are many such success stories. So I prefer giving topical injectable therapy. Another student, 16M, who was being ridiculed in the school and stopped going to school. So we did a nail bed biopsy. It was consistent with psoriasis. I gave intrametricial and intra-bed injection because he had both the disease part, and all 20 nails were involved. But her mother was a school teacher who denied methotrexate or any other immunosuppressive therapy. I have developed a technique where in one injection I can give both intrametricial as well as nail bed lesions injection. And this was the result after 3 sessions and after 6 sessions. And on the other hand, so this can be maintained easily with topical emollient application. I've been following this child for almost. We also tried nail bed methotrexate injection in isolated nail psoriasis. We published the series in CED. These were the results, but I'm not using it because intrametricial or intra-bed injections are very, very painful. Because the methotrexate injection, if you see, it's highly viscous, it's lipid soluble, and it's extremely painful. So I am happy with intrametricial or intra-bed triamcinolone acetonide. What are the criteria for systemic therapy if only nail is involved with psoriasis? If there is dual QI score of more than 10, PASI more than 10, or BSA more than 10. And there has to be psoriatic arthritis. So systemic therapy, we have methotrexate, acetretin, cyclosporin, and they were found to be equally effective, except that methotrexate was found to be good for nail matrix lesions, while the cyclosporin was found to be better for nail bed lesions. Then there are different studies on biologics for the nail psoriasis, and this is a network meta-analysis which says that out of all the biologics available, tofacitinib and ixekizumab presented the best efficacy for the treatment of nail psoriasis in 10 to 16 weeks and 24 to 36 weeks respectively. Ixekizumab 80 milligram every 4 weeks and etanercept 50 milligram twice weekly also proved to be the short-term treatment, best treatment options. Coming to nail lichen planus. Now the nail lichen planus can occur in 10% of the cases of mucocutaneous LP. Only 25% of the nail lichen planus have skin lesions. But isolated nail planus is more disabling disease than psoriasis because it's potentially scarring. Because once the pterygium sets in there, you cannot do anything at all. And it has got severe negative impact on the quality of life. Again, the clinical presentation depends on whether the nail matrix or nail bed is involved, and therefore you can have nail plate thinning, onychorexis, longitudinal melanonychia, pterygium, and anonychia in severe cases. This is the classical pictures of nail lichen planus: thinning, ridging, splitting, and melanonychia. Again, thinning, there is longitudinal splitting, and you can see pterygium formation in so many nails, even on third nail. So once it has started, any treatment is ineffective. Another patient, and there is anonychia in severe cases, because if patient comes late, it becomes very difficult to give them a control. So what are the treatment options for nail psoriasis? You can give highly potent topical steroid. I do give under occlusion, but you have to be very, very careful because there can be depigmentation and atrophy. Or intramatricial, if there are few. But what works best is the systemic steroid, 0.5 to 1 milligram per kg of triamcinolone acetonide intramuscularly every week. Other options include methotrexate, hydroxychloroquine, and acitretin, but triamcinolone acetonide intramuscular injections remains the best in my experience. So this is a child who was just 5-year-old, and it's extremely rare to have this severe nail lichen planus in such a small child. I relied my clinical acumen and the onychoscopy finding to make the diagnosis, because it was very difficult to do nail matrix biopsy on him. And I gave intramuscular 10 milligram triamcinolone acetonide, and this was after 7 injections. And the child is maintaining the outcome. Another patient who is still under follow-up, and the results are awesome. And you can give topical tacrolimus in addition, because that's a drug which is not associated with any systemic side effect. And I prefer using finger gloves. They are freely available on Amazon. The patient applies tacrolimus, and then he can wear finger gloves and good to go. Coming to nail in autoimmune, oh, my time is up. Autoimmune blistering diseases, pemphigus and bullous pemphigoid. So you can see this is an active disease where there are blisters in the proximal nail fold and on the hands and feet, and it corresponds, the presence of nail lesions corresponds directly with the severity of the disease of both pemphigus and pemphigoid. And second very, very important point is that we have seen in our clinical practice, when there is relapse, nail lesions are first to come. So they can be a marker for the relapse, they can be the marker for the severity of the disease. Chronic paronychia, hemorrhagic bullae, you can see and if the disease is very severe involving the proximal nail fold, you can see onychomedicis in all 20 nails, all fingernails, you can see. So this happens when there is severe involvement of the matrix for a prolonged time. And these are the beautiful Bose line, and this also corresponds with the dexamethasone cyclophosphamide pulse, which we give monthly. So patient will have cyclical line. Coming to nail changes in CTD, they are not specific, but very, very important is nail fold capillaroscopy. Again, you must have learned in the workshop. Systemic sclerosis, there are ragged cuticle, paronychia, periangular erythema, which are common to all connective tissue diseases. But nail fold capillary is very, very important. It's in vivo assessment of microcirculation. And it is, this is very, very important diagram. It gives, how the orientation of the nail fold vasculature is. How do you see? So it helps to detect and monitor the diagnostic feature of systemic sclerosis, early microvascular changes, and complications like retinopathy, neuropathy, and nephropathy. So all patients of SLE who are likely to get these complications are routinely followed up by NFC assessment. So you need DL3, DL4, or video dermatoscope, and technique is that you make the patient comfortable. It should not be very cold. Clean, remove the nail paint, and polarized onychoscopy is used. We do 2 parameters, qualitative and quantitative. In quantitative, you know the number of the density per millimeter, and in qualitative, morphological changes. So these are the these are the normal capillaries. These are the dilated. The second one are the dilated.
Excuse me, Dr. Archana, please kindly try to.
Yeah, just last year, sir. And then there are hemorrhage, bushy capillaries, tortuous capillaries. So these are the pictures. These are normal. There are 7.6 capillaries per millimeter. And in systemic sclerosis, which is also, Euler criteria, there are hemorrhages, there are giant capillaries. This is early change, capillary dilatation. There you see avascular area, again avascular area, which means it's late systemic sclerosis. And these are again capillary dilatation and capillary dilatation with hemorrhage. Again avascular area and hemorrhages. So these are, and this is just capillary dropout. Dropout means less than 2 capillaries are absent, while avascular area more than 2, and these are different morphological. So the carry-home message is that nail is a fascinating word of science to explore. That's important for dermatologists. It's important to identify the problem early, and because most of the diseases are treatable. Thank you very much for your kind attention. And this is the book, if you can go through.